Bismillahirrahmanirrahim. Quote of the day is, and your Lord had said, pray unto me and I will hear your prayer. This is the quote from Quran. My name is Dr. Aamna Khalid. I am PGR Community Medicine. And today I will presenting the topic of pertussis under the kind supervision of Professor Dr. Saira Afzal, who is Dean Institute of Public Health, Lahore. The learning objectives of today's presentation are introduction to pertussis, epidemiological determinants, clinical features, phases and complications, diagnosis, prevention and control measures, global and national burden, recent advances, and then the practice of MCQs. So, pertussis is an acute bacterial infection of respiratory tract, and it basically involves trachea, bronchi, and bronchioles, and typically the cough remains from 1 to 2 months or even more than that. The incidence of pertussis is cyclical. It's a cyclical disease with peaks occurring roughly every 2 to 6 years. This is the epidemiological history of pertussis. That it was first described during a major epidemic in Paris in 1578. Then in 1906, the bacteria Bordetella pertussis was isolated and confirming the cause that it's a bacterial disease. Then there was the pre-vaccination area where the major cause of childhood illness and death with frequent global outbreaks were occurring. In 1940s, there was introduction to the whole cell vaccine that markedly reduced the cases up to more than 90%. Then in 1990s, many countries then switched to the acellular type of vaccine due to its better safety profile. The current status of pertussis is that it remains endemic worldwide, with infants of less than 1 year at highest risk. And the modern development in this era is that the maternal vaccination has been developed called Tdap for the as well as the adolescents and adults as a booster dose and improved vaccine development. And the dynamics of disease transmission, humans are the only reservoir for the pertussis virus, and the mode of transmission for it is respiratory route, either via the droplet infection during coughing and sneezing or through the direct contact. And incubation period ranges from 4 to 21 days, during which the virus multiplies in the body without any visible symptoms. And the epidemiological determinants include agent factors, host factors, and environmental factors. The agent factors are that the causative agent is Bordetella pertussis, it's a gram-negative Coccobacillus, and its key virulence factors are pertussis toxin, filamentous hemagglutinin, pertectin, tracheal cytotoxin, and the fragile organism does not survive uh, for a long time outside the human body. Host factors include age. The highest risk group is the infants less than 1 year, especially less than 6 months. Immunity is the winning immunity after infection or even vaccination. And vaccination status, unvaccinated or partially vaccinated individuals are at highest risk. If there are comorbidities like chronic lung disease, prematurity of the children increases the severity. In occupational or exposure risk, healthcare workers, caregivers, and mothers of young infants are at greater risk. Then we have the environmental factors, living conditions like crowding, as seen in schools, households, and daycare centers, they facilitate transmission. Seasonality, like cases may peak during late summer to early fall, though seasonality varies. Overventilation, if it's there, it increases airborne spread. Then healthcare access, if the access is limited to the services and immunization programs, especially in the underdeveloped areas, it will increase the likelihood of outbreaks. These are the major overall symptoms, clinical features of pertussis, including paroxysmal coughing fits. These are severe. inspiratory woof. There can be post-tussive vomiting. Cough can be prolonged even up to many weeks. Apnea, especially in infants. Cyanosis during coughing and along with low-grade fever. Phases of pertussis are three. First is the catarrhal phase, then the paroxysmal phase, and then we have convalescent phase. Catarrhal phase lasts from the initial 1 to 2 weeks. It's the early stage, resembling just like an upper respiratory infection, and symptoms are runny nose, mild cough, low-grade fever, sneezing, and malaise. Bacteria at this stage multiply rapidly in the respiratory tract, so it's the most infectious stage. It's hard to differentiate from common cold at this point. Then the second one is the paroxysmal phase that lasts from 2 to 6 weeks or even longer. This phase is characterized by paroxysm like bursts of severe repetitive coughing that's followed by the classical inspiratory whoop, especially in children. They can be post-tussive vomiting, cyanosis, exhaustion after coughing fits. Coughing episodes are more frequent at night. Infants may show apnea instead of whoop, and there is very little fever at this stage. Then the third one is the convalescent phase that lasts from weeks to even months. This is a gradual recovery stage. Cough becomes less severe and less frequent, but may persist for 2 to 3 months. That's why Chinese called it 100-day cough. Occasional paroxysms may still occur, especially with respiratory infections. Now we move forward to the early and delayed complications of pertussis. Early complications include apnea, especially in infants, pneumonia, that's secondary bacterial infection, seizures, hypoxia or cyanosis, dehydration due to vomiting, otitis media if air infection occurs. These are the delayed complications. The weight loss or failure to thrive can be there, hernias due to severe coughing, rib fractures, again from intense coughing, rectal prolapse due to increased abdominal pressure. The neurological deficits, these are rare but can occur due to hypoxic episodes. We discuss the disease occurrence in pregnancy. The risks to the mother are mild. There can be prolonged cough, paroxysms, post-tussive vomiting, and complications are uncommon but can include pneumonia, exacerbation of pre-existing asthma, or rib fracture due to severe coughing. Risk to the fetus are that vertical transmission is rare, and risk is actually mainly postnatal through close contact with the mother. Newborns infected from a mother or household contacts can develop severe pertussis, apnea, and pneumonia. And hospitalization and death in infants in less than 3 months can occur in case of severe disease. Prevention in pregnancy can be through a maternal Tdap vaccination that's given 27 to 36 weeks gestation, and it provides passive immunity to the newborn as well. It reduces pertussis incidence and severity in infants, and encourage household contacts as well to keep their vaccination updated. How to manage a pregnant lady with pertussis? We have to give antibiotics, including macrolides. Azithromycin is the preferred choice. The infant in supportive care include hydration, rest, symptomatic management. These are some of the differential diagnoses: viral upper respiratory infection, bronchiolitis, asthma, and we can also think of parainfluenza infection. Diagnosis is made on the clinical basis or the laboratory test. The clinical diagnosis, as already discussed, that the cough lasting for 2 weeks or more than that, if it's paroxysmal and along with inspiratory woof, post-tussive vomiting is there. And infants, if they are showing apnea, cyanosis, or poor feeding, we should think of pertussis. Laboratory tests are classified into three categories. The first is microbiological, nasopharyngeal swab or aspirate. Culture is the gold standard, but it has low and slow and but it's slow and less sensitive. PCR is faster and more sensitive, especially in early disease if it's at a less than 3 weeks stage. Then the second category is a serology. Anti-pertussis toxin antibodies. These are useful in later stages for more than 2 to 3 weeks when culture or PCR may be negative. Additional clues can be from CBC that leukocytosis is there with lymphocytosis. It's common in infants. Chest X-ray if pneumonia is suspected. Now we move to the prevention. The first level is the primary prevention, and it includes vaccination of infants and childhood, adolescents and adults, and maternal vaccination. And then we have health education regarding the hygiene and infection control and community level measures. So first of all, we will discuss the vaccination of infants and children. The vaccine is administered as part of the pentavalent vaccine. It's DPT combination, diphtheria, pertussis, and tetanus. Uh, the vaccine used in EPI schedule of Pakistan is wholesale pertussis vaccine. Its first dose is given at 6 weeks of age, second dose at 10 weeks, third dose at 14 weeks, and a booster dose is recommended by WHO, preferably during the second stage of life. So here you can see the EPI schedule that during the second, third, and fourth visit, that's 6, 10, and 14 weeks respectively, pentavalent 1, 2, and 3 are given, and that includes the pertussis vaccine. Dose of this vaccine is 0.5 ml per injection. Route is intramuscular. And in this case, like we are discussing the case of infants, the preferred injection site is anterolateral aspect of the thigh. Its efficacy after 3 doses is up to 83.5%. Then we have the vaccination schedule for adolescents. Tdap vaccine is used for them. Again, its dose is 0.5 ml and it's also given intramuscular, but the preferred injection site is deltoid muscle now. The recommended schedule, again, as recommended by WHO and updated on the CDC website, is that it's a single dose of Tdap at 11 to 12 years of age. Then we have a catch-up vaccine schedule. If the vaccine is missed at 11 to 12 years, we can give Tdap at next opportunity, like up to age of 18 years. And also for those who only had tetanus and diphtheria vaccine or whose prior pertussis containing vaccination history is incomplete. Then we will discuss the vaccination process in pregnancy. Again, the vaccine in pregnant women is Tdap. This vaccine type is acellular pertussis vaccine. Small d actually indicates reduced dose of diphtheria. Dose is 0.5 ml. Injection site is deltoid. It's given intramuscular. Now the recommended timing is 27 to 36 weeks of gestation. It comes under the third trimester, but ideally we should not cross the 32 weeks. It should be given between 27 to 32 weeks to maximize transplacental antibody transfer to the newborn. Efficacy of the vaccine when given to the pregnant lady is that it provides passive immunity to the newborn via maternal antibodies. It reduces the risk of pertussis in infants of less than 3 months by up to 90% in some studies. Protects infants before they can receive their own vaccine, and maternal vaccination also protects the mother, reducing the chance of transmission. Then another thing that can be done in primary prevention is cocooning. What is it? It's the process of vaccinating all close contacts of newborns to prevent transmission. The target groups in this case is the parents, siblings, grandparents, caregivers, household members, and any person who is in close contact with the infant. Vaccine used in this case is also Tdap if it's not vaccinated within the last 10 years. Goal is to create a protective cocoon of immune individuals around the vulnerable infant. Its effectiveness is that it reduces the risk of infant pertussis before they can receive their own vaccine. So this is actually the repetition and summary of the vaccination schedules that people of all ages should get the whooping cough vaccine, the recommended schedule by a CDC. And you can see that young children are using DTaP vaccine, but all the preteens, pregnant women, and adults should use Tdap vaccine. Schedules are already discussed in the previous slides. Then health education also comes under the primary prevention level, that we should follow the infection control measures. Cups should be covered, hand hygiene should be maintained, avoid sharing utensils, isolate the case for 5 days after antibiotics have been started. Seek early medical care and complete antibiotic courses. And this should also be taught to them, educated to the people. Promote community awareness and correct misconceptions about waning immunity. Then comes the level of secondary prevention that includes early diagnosis and treatment, contact tracing and screening, and post exposure prophylaxis. So, the early and prompt treatment includes antibiotic therapy. The purpose is to treat the infection, reduce severity, and prevent spread to others. The preferred antibiotics are macrolides, and if macrolides are not tolerated, then trimethoprim sulfamethoxazole can be used only in if a patient is more than 2 months old. And if it's most effective is started during the catarrhal stage or even in the early paroxysmal stage. Supportive care should be given that infants, if they have severe symptoms, they should be hospitalized, they should be hydrated, oxygen therapy if required in case of hypoxia or severe respiratory distress. Nutritional support should be given as there is post-acid vomiting, symptomatic treatment for fever, and humidified air positioning to reduce coughing. Contact tracing is to identify and manage individuals who were exposed to a confirmed produces case. All the close contacts of the patient should be traced, and high risk contacts are infants, pregnant women, and immunocompromised people. What we have to do is screen for the symptoms, offer them post exposure prophylaxis, we will discuss in the next slide, and educate on the early symptoms of the disease. Goal is to prevent secondary cases and limit outbreak spread. Post-exposure prophylaxis prevent pertussis in recently exposed individuals and reduce transmission to high-risk groups. And who should be given this prophylaxis? Infants of less than 1 year, pregnant women in third trimester, household and close contacts of confirmed cases, immunocompromised individuals. And it should be given within 21 days of exposure, and recommended antibiotics are again macrolides, or if it's not tolerated, trimethoprim. Tertiary prevention includes management of complications, minimizing long-term sequelae of neurological complications and other rib fractures, hernias, erector prolapse. Rehabilitation and follow-up should be continuously done. These are the major outbreak control measures, that case identification and isolation should be done. Contact tracing and their post-exposure prophylaxis should be done. Mass immunization campaigns and enhanced surveillance and reporting can reduce the outbreaks. This is the global burden of pertussis, that average annual cases before the COVID pandemic were approximately 1,70,000, and during the pandemic the cases declined to 29,000. And again there is rise in the cases, like in 2022 there were around 63,000 cases, and in 2023 1,58,000 cases, and in 2024 several regions are again experiencing increased number of cases. This is the CDC global data for pertussis cases. You can see that the cases had almost were very decreased from 1970 to around 1990 or even 2000, but then the cases again started to increase Although the curve is haphazard, but we can see the rise around in 2008 or 10, and then again around 2015 and onwards. And you can also see the introduction of different types of vaccines, like DTP introduced, and DTaP and TDAP. These are the reported cases by age group, and you can see that the green line shows the children of less than 1 year, and it's the highest incidence. The dark blue color shows the highest number of cases, and the light blue lower number, and the white color shows the that data was not available. But Pakistan is in the light blue color, that cases are reported, but they are less. Now, the national burden of pertussis, it's endemic all the time in Pakistan, and the recent case count for the mid 2025 was that the um, 48 suspected cases were there. And a study from Karachi in 2016, although it's an old study, but it showed that there were 3.96 cases per 1,000 infants, and the vaccination coverage is 87% for the pertussis in 2024. So you can see that it's the data from only 1 week, and there were around 75 cases of pertussis were reported. This is the data from the public health laboratories taken from the NIH website, and you can see that pertussis was not reported by any lab. It means that reporting from lab public health laboratories is low in Pakistan. Then we move to the recent advances. This is a study in navigating Pakistan's immunization landscape, progress, and pitfalls. And it says that there is incidence of various vaccine preventable diseases in the flood affected regions, and pertussis showed a 171% increase in such areas. Under the umbrella of NIH, the Advisory for the Prevention and Control of Pertussis was made in 2024, and the objective was for the timely prevention and control measures, and also the preparedness to deal with the increased workload expected in the outpatient and inpatient departments during the next few months regarding pertussis. So this was the global childhood vaccination coverage held by WHO and UNICEF, and but they still claim that 14 million infants were still unvaccinated. Pertussis is discussed as a re-emerging threat despite immunization, and the reason for that pertussis is not being able to eliminate from any country is that there is waning immunity, asymptomatic transmission, vaccine type differences, and vaccination gaps. Now we move to the practice of MCQ. The first question is: pertussis is an acute bacterial infection of respiratory tract. Which of the following is not true in relation to pertussis infection? Option A, most infection during lateral stage. Option B, secondary attack rate is 90%. Option C, subclinical cases are source of infection. Option D, infants are susceptible from birth. And option E, pregnant women are susceptible.
B.
It's option C. The question was which is not true. Question number 2 is: whooping cough or pertussis can be a serious disease for people of all ages, but especially for babies. Whooping cough vaccines offer the best protection against this very contagious disease. All of the following are correct regarding pertussis vaccine except option A, pertussis vaccine does not provide lifelong immunity. Option B, pertussis vaccine is safe for lactating mothers but not for pregnant women. Pertussis vaccine offers good protection for first 2 years of vaccination, then the effect starts declining. Pertussis vaccine is not available and recommended to newborn baby by CDC. Booster dose is required at 4 years of age. Option A is the correct one, as booster dose is not required at 4 years of age, but it's required during the second year of life. In question number 3, pertussis is a highly contagious disease severely affecting children less than 1 year of age. The best way to prevent it is immunization. Following statements are true regarding control of pertussis except option A, isolation of cases, option B, passive immunization of contacts, option C, concurrent disinfection of nose and throat discharges. Option 4, 14 days course of erythromycin for contacts, and option E, 3 phases are seen in whooping cough. Option B is the correct one, as passive immunization of contacts is actually not the reality. Question number 4 is a baby was brought to emergency department with complaints of paroxysmal cough for more than 2 weeks, followed by vomiting leading to apneic spells. Her lab investigations were done to confirm the suspicion of pertussis. Which of the following investigation is readily available in most of the labs with high sensitivity? Option A, PCR. Option B, blood culture. Option C, ELISA. Option D, urine culture. Option E, throat swab. Option A, yes, option A is the right answer. Question number 5 is pertussis vaccination during pregnancy could protect infants against pertussis disease before the routine vaccination. Which type of vaccine is given during pregnancy and when? Option A, Tdap in first trimester. Option B, Tdap in third trimester. Option C, Td in third trimester. Option D, Dtap in third trimester, or Tdap in second trimester. It's it's option it's option it's option B, Tdap in third trimester. A 2-year-old the child with history of contact with pertussis develops bouts of cough, inspiratory whoop, and post-tussive vomiting. Which of the following phases not is most contagious? Most contagious. First option is catarrhal stage or paroxysmal stage, post-paroxysmal stage, incubation stage, or latent stage. Yes, option A is the right answer. Question number 7. Pertussis in infants is often severe, and infants are more likely than older children or adults to develop complications. The most common complication of pertussis and the cause of most pertussis-related deaths is option A, bacterial pneumonia, option B, encephalopathy, epistaxis, or syncope, or hypotension. Option A, yes, option A. Question number 8. A 3-month-old infant is diagnosed with pertussis. His 8-year-old brother is fully vaccinated and asymptomatic. What is the best next step? Option A, no action needed because he is fully vaccinated. Option B, give a booster dose of DTaP only. Option C, give macrolide prophylaxis, or isolate him for 14 days, or test him with PCR first and treat if positive. Options Option C is the right answer because the case was confirmed
बगैर
case,
स्पीकर ऑन
so
कर
his
दिया
contacts should be a 48-year-old pregnant woman at 32 weeks gestation presents for a routine antenatal visit. She received Tdap 3 years ago. She asks if she still needs the vaccine during this pregnancy. What is the most appropriate recommendation? Option A, no vaccine needed. Option B, give Tdap immediately during this visit. Option C, delay Tdap until after delivery. Option D, give DTaP instead of Tdap. Or option E, give Tdap only if she has close contact with infants.
E
9B, we should protect each pregnancy irrespective of the previous schedule. Question number 10. A school requires proof of pertussis vaccination for all students. A 14-year-old girl completed her childhood DTaP series but has had no boosters since. What is the most appropriate vaccine? Option A, DTaP, or Tdap, or TD only, or no vaccine needed, or PCV13.
C.
No, it's B, Tdap, as she is 14 years old. So this is the answer key. This is the channel of Institute of Public Health Lahore where this presentation will be uploaded. Thank you.
Thank you, beta. Thank you.
Thank you so much, Dr. Amna. It was a very good presentation.